Good afternoon, and welcome to Reproaction's Act and Learn webinar for January 2024. It's going to be a solid year of important work for abortion rights and reproductive justice. So we're so excited you're joining us for today's extremely important topic, which is on the propaganda of anti-abortion crisis pregnancy centers, which are not pro-loving and not pro-women. So first we'll introduce your host. First voice you're hearing is Erin Matson. I use she, her pronouns. I'm co-founder, president, and CEO of Reproaction. I'm based in Washington, D.C., and I'm Erin to the Max on social media.
And the second voice you will be hearing is Layla Salam. I use she and her pronouns, and I'm the DC organizer of Reproaction.
Great. Thank you so much. All right. So first we'll go through the agenda. We'll introduce Reproaction. Then we'll do some introduction to the topic on anti-abortion crisis pregnancy centers. We're extremely excited about our panel discussion for today. We have Jennifer McKenna from the CPC Accountability Program, Catherine Riley from Calora Latina, and we are expecting Dr. Sarah Immersheim, an abortion provider. She has not joined us yet, but we're hopeful she'll be able to be here by the time of her presentation on the panel. Then we'll cover next steps, and we'll do Q&A at the end. So for all questions, please put them into the questions tab, and we'll get to as many as possible at the end. There's no need to wait to put those into the questions tab. So if you have questions at any point, just put them into the questions tab. We'll get as many as possible at the end. And if you are still on the artist formerly known as Twitter, you're welcome to join the live conversation there on the Reproaction hashtag on X. Okay, so a brief introduction to Reproaction. Reproaction leads bold action to increase access to abortion and advance reproductive justice. We're incredibly proud of our left flank analysis and for our willingness to hold folks on all sides accountable, whether they're traditionally considered allies or opposition. We have a deep commitment to nonviolent direct action as one of the tools in our toolbox. So first, just to set this up, what is an anti-abortion crisis pregnancy center? They call themselves a lot of different things. They call themselves crisis pregnancy centers. Sometimes they call themselves pregnancy resource centers. We often call them anti-abortion state clinics, whatever you want to call them. They exist to mislead and shame people seeking abortion care. I want to ground and center this conversation that this is about so much more than the services that they claim to offer and the people that they mislead. The anti-abortion state clinics are strategically important to spreading anti-abortion hatred and passing abortion bans around the nation. Anti-abortion crisis pregnancy centers exist in all 50 states at the community level, and they regularly spread disinformation about pregnancy and how our bodies work. Nationally, there are nearly 2,400 anti-abortion crisis pregnancy centers in the United States. And I want to encourage you to check out our resource of state clinic database at reproaction.org/state clinic database, where you can see where they are in your community. We know a lot of folks actually use these, like abortion funds will sometimes use them literally while they're live on the call with patients, calling in to see if the place that they're reporting is in fact an anti-abortion state clinic or not. It's really important. You know, a lot of the times they frame themselves, they're like volunteer or mom and pop and just grassroots folks doing work at the community level. That's hogwash. These places collectively take in billions of dollars each year in the United States from a variety of total funds, including private foundation funding, donations from religious groups, sometimes taking state funds, sometimes in even some cases using federal dollars, block granted for TANF, for temporary assistance for needy families. Some states allow those to be diverted to anti-abortion crisis pregnancy centers, which may be about to change, which would be very welcome. But just to be clear, the big picture of which they operate. And it's also important to note that anti-abortion haters often try to change the subject to anti-abortion crisis pregnancy centers, framing them as like this shows that the force behind abortion bans is actually super loving and caring about women and babies, and to be clear, people of all genders get pregnant and have children. That's the language they use. But just talking about the fact that abortion bans are that the anti-abortion movement is eager to talk about crisis pregnancy centers right now because they're desperate to change the subject, because abortion bans are extremely unpopular. Abortion has won every single time it has gone on the ballot since the Dobbs decision overturning Roe versus Wade. Today, and the landscape for abortion access is much worse in this country since the Dobbs decision, to be clear. Today, 21 states ban abortion entirely or restrict it to levels earlier in pregnancy than before the Dobbs decision. It is chaos in the healthcare system. And abortion bans have created chaos for people seeking and needing abortion care, creating horrific stories, things like patients being encouraged by the doctors to go into sepsis in a hospital parking lot before they're able to receive their life-saving abortion care. OBGYNs leaving states and maternity care becoming less available because doctors are being prosecuted, and even deaths that could have been prevented. There was a story that just ran in the New Yorker about a woman in Texas who recently suffered death during pregnancy, where the experts were speaking pretty frankly that if therapeutic abortion had been discussed and agreed to, she almost certainly wouldn't be dead. And she should have at least had that option. But the fearful environment that has been created by these abortion bans are leading to horrific healthcare situations. So this is the backdrop against why the anti-abortion movement is and anti-abortion leadership is so desperate to change the topic right now to their so-called nice crisis pregnancy centers that are in fact systematically lying to, misleading, and shaming people. So just to dig into that a little more, instead of the unpopular abortion bans that are creating suffering as the focus, anti-abortion leaders want to use crisis pregnancy centers to present a message that their movement is loving or pro-woman or pro-baby. And again, this movement is not loving, it's not pro-woman or not pro-baby. This is something that Leonard Leo and right-wing folks who do not agree with democracy in this country have invested millions and billions of dollars into restricting people's agency over their bodies to support an authoritarian country without religious freedom, true religious freedom. So while their anti-abortion laws and abortion bans cause all of this suffering that we're seeing in the United States right now, they are saying, this is so strange. They are saying that the place where their movement is already raking in billions of dollars, crisis pregnancy centers, as I said, in the U.S., collectively in the U.S. are taking in billions of dollars a year to get even more money, and they're trying to get it from public funds. So parents phrase that like they're like, look, we're banning abortion. Now please fund our core operating infrastructure, because they have these centers all over the country that do not provide evidence-based care and regularly deceive people so that we're able to increase our power and do more abortion bans. And that's just a non-starter. So just an example of that, this year's so-called March for Life, every year anti-abortion folks do a march on the National Mall to attempt to show support for the anti-abortion position, make it seem much bigger than it actually is, because we know that reproductive freedom is popular in this country, and in fact, it's only more popular. They'd rather put their theme around anti-abortion fake clinics this year than be honest that they're once again marching with people wearing MAGA hats and white supremacists to do more abortion bans, because that's what it's really all about for them. So with that, I will pass it to Layla to give us some additional information and grounding on fake clinics before we move into our panel discussion.
Thank you so much, Erin, for all that background. I'm just going to quickly recap a couple of the things Erin said and distill them into some shorter points. So as you all have heard, anti-abortion fake clinics portray themselves as unbiased medical facilities, while in reality, they're driven by an extreme opposition to abortion and are driven by pro-life organizations that we all know that contribute to this extreme opposition of abortion and fund these fake clinics. So as Erin mentioned, many of these fake clinics do not have any qualified medical professionals on staff, meaning that they cannot actually provide comprehensive prenatal care or pregnancy counseling, and often refuse to provide support for people after they've given birth. So in a lot of cases, they're coercing people who have gone to their facilities thinking they could get abortion care. They kind of fill them up with all of these promises that they can support them after they've given birth, and then oftentimes abandon them. So fake clinics, as I mentioned, are typically affiliates of highly funded, entrenched pro-life organizations like Heartbeat International and CareNet, but they often go by deceptive names to suggest that they are either real medical providers or to suggest that they are abortion providers. In addition to this, they often receive state funding that is meant for families in need through different grant programs or to support the provision of necessary healthcare services for pregnant people and their families. And they're diverting these funds away from these direct need and action avenues into their fake clinics. It's also important to note that, particularly after the fall of Roe v. Wade and after Dobbs, that anti-abortion fake clinics now outnumber actual abortion clinics 3-to-1. So it's even more critical that we're paying attention to these organizations and what they're doing and the way that they are diverting people from getting the care they actually want. And with that, I think Erin can take us into our panel.
Great, thank you so much. And I'm going to get started with Jennifer McKenna. Layla, just as a point, could you please send Shireen from our team Dr. Sarah's phone number so that she's able to try to get her on the line while I start with Jennifer? So I will now be very pleased and proud to introduce Jennifer McKenna, who's the Director for Crisis Pregnancy Center Accountability at the Reproductive Health Accountability Fund at Hopewell, which works to advance a high-impact agenda to disrupt the crisis pregnancy center industry and build the infrastructure for reproductive health care in the U.S. Jennifer brings more than 30 years of reproductive and gender equity advocacy to this role and deep experience and expertise in the anti-abortion CPC industry. She's co-founder of the California Women's Law Center, where she served as managing director, leading statewide advocacy on reproductive rights, gender-based violence, and gender discrimination. For 10 years, Jennifer coordinated the Alliance State Advocates for Women's Rights and Gender Equity. She also directed the Alliance CPC project, leading the first multi-state crisis pregnancy center investigation, and co-authored a real bang-up national report designed to deceive, a study of the crisis pregnancy center industry in 9 states. She's also a contributing reporter on crisis pregnancy center issues for Ms. Magazine. Jennifer, thank you so much for making the time to join us today.
Thank you so much. Can you hear me?
Yes, I can hear you very well. And so my first question for you is, from your research, what is the discrepancy between the services that crisis pregnancy centers claim to provide and what they are actually doing?
Yes, and first I want to thank Erin for that awesome summary of the role of crisis pregnancy centers in the anti-abortion movement, really critical information. And to thank all of you at Reproaction for your advocacy and research and direct action on this issue. It's just been essential in the movement. As Layla indicated, I led this coalition of gender equality law centers in an investigation of over 600 CPCs in 9 states in 2020 and 2021. And we published the national report Designed to Deceive and called it that because we found that CPCs across states systemically use deception and disinformation to reach people with unintended pregnancies and prevent them from accessing abortion and contraception. And we also learned really documented that CPCs are part of a coordinated, well-resourced anti-abortion industry. So I want to briefly highlight some of our primary takeaways from our study about what CPCs are and do. I'm going to call them crisis pregnancy centers or CPCs, which we also know as anti-abortion pregnancy centers or fake clinics. The four major takeaways from our study were that number one, CPCs often presented themselves as health clinics, but the 6 services they typically provided served no medical purpose. Secondly, we found that CPCs use deceptive marketing to signal they provide healthcare and unbiased services. Number 3, we found that CPCs trafficked in medical disinformation. And number 4, we found that they brand themselves as local, but that most are directly connected to evangelical Christian, anti-abortion, anti-LGBTQ advocacy groups. I'm going to give you a little detail under each of those findings. And all of this is critical information in understanding why what, as Erin said, their claims to actually be meeting the needs of pregnant people post-Dobbs is hogwash. It's gaslighting. Finding number 1, that CPCs often presented themselves as health clinics, but the 6 services they typically provided served no medical purpose. We found that they offer 3 services that are cherry-picked from actual health clinics in order to get people in the door. Urine stack pregnancy tests, ultrasounds, which they use to persuade people to carry to term, and ultrasounds, which they offer in the first trimester, which is not a standard of care. And number 3, sexually transmitted disease tests to get young people in the door. We found that virtually none provided prenatal care, and most didn't even bother to make prenatal care referrals. We found only 1 provided contraception. Those offering STI tests provided no treatment or condoms for prevention. They were overwhelmingly staffed by volunteers, not licensed professionals, and those that claimed to have medical professionals did not name them, list their credentials, or disclose whether they were employees or volunteers. The other 3 services CPCs typically offered were pregnancy counseling, and I put that in air quotes, not by licensed professionals, but by volunteers trained under a national group's biblically based training curriculum, or other baby supplies. And I put that in air quotes because pregnant people often had to earn the diapers by watching an anti-abortion video or participating in Bible study or some other CPC programming. And then finally, they offered sexuality education, again in air quotes, because content promoted abstinence, disinformation about contraception, and harmful stereotypes about LGBTQ people. That's it. All CPCs offered some combination of this limited suite of 6 ideological or non-medical services, a stark contrast with the comprehensive array of professional healthcare and counseling services offered by real clinics. Second finding, a little detail. CPCs use deceptive marketing to signal they provide healthcare and unbiased services. We found their advertising made it hard to distinguish them from real clinics. They often position near abortion clinics and using the same names and signage that mimic the abortion clinic. Post-Dobbs, they're still near former abortion clinics trying to divert people away from contraceptive care and other reproductive health care provided by those real clinics. Their websites used clinical language and stock images of people in lab coats. They invested heavily in Google ads to appear first in online searches for people seeking abortion, which they've doubled down on post-Dobbs, by the way. And their ads and websites claim to provide unbiased information and disguising that they were anti-abortion and religious organizations. We also found they explicitly marketed themselves to uninsured people, women of color, and young people. Some CPC websites had whole pages aimed at students with directions from colleges and even high schools to the center. In short, we found CPCs used deceptive advertising as a business model. Finding 3, a little detail. Most CPCs trafficked in medical disinformation. The majority of CPCs in our study promoted false medical claims, abortion, and contraception that would scare people. And we saw the same claims over and over on CPC's websites in all states. Claims that have been roundly debunked as junk science, like a breast cancer or abortion causes breast cancer, which the American Cancer Society says no, or abortion causes depression, the American Psychological Association says no. Many promoted made-up post-abortion abortion recovery syndromes, and over a third promoted the unproven anti-abortion movement claim that a medication abortion can be reversed. These 3 main takeaways from our study confirmed what a long line of CPC investigations over the past 20 years have also found. CPCs use deceptive advertising to lure pregnant people and faux medical services and disinformation to prevent them from accessing abortion and contraception. We also, by the way, found that the state-funded CPCs in our study, 2 of the states were funding CPCs, were the worst offenders. They provided prenatal care less often and prenatal care referrals less often than the abysmal rate of the privately funded CPCs, and they promoted abortion pill reversal more often. But I'm going to speak a moment to speak about our 4th finding, which really was a sort of a new wake-up call about the central role of CPCs in the anti-abortion movement, which is critical to understand post-Roe. While CPCs branded themselves as local, we found they are not local or independent. They're part of a global anti-abortion Christian nationalist movement. Most CPCs in our study were directly affiliated with large anti-abortion groups. A new report last summer found almost half the CPCs in the country are not even incorporated as standalone groups. They share their tax ID number with the national group. These national and global groups provide CPCs with funding, training, marketing, web content, ultrasound equipment, legal defense, and more. And critical post-obs, they're collecting and storing client data with no privacy protections because they're not health clinics, and feeding that data to a central anti-abortion movement database held by Heartbeat International, data that could be used in pregnancy-related prosecutions post-Roe. There's recently been publication about a case pre-Roe in which a CPC provided information on a client in Alabama to support a pregnancy prosecution of that client. In short, CPCs have been around since Roe, operating under the radar without regulation or accountability. They brand themselves as health clinics or benign helpers of pregnant women. This is gaslighting. They exist to impose an extreme political agenda and to impose their evangelical values on pregnant people. They obstruct access to all reproductive health care. And this is, as we face a worsening crisis in maternal mortality, especially Black women. They're storefronts for the Christian national movement, mobilizing sites for radicalizing anti-abortion activists. The CPC industry is a grift and a grave threat to the public health. And in recent years, they've expanded in scope and power by obtaining escalating amounts of public money, as Layla referenced, and they're collecting sensitive patient data in an environment where abortion and adverse pregnancy outcomes are criminalized. So that's the bad news. There is good news that there's new scrutiny and new efforts at holding them accountable. If we have time later during the Q&A, we can talk a bit about that. Thank you so much.
Thank you, Jennifer. That was so comprehensive and such important grounding for this discussion. And thank you for your life's work to combat these right-wing radicalization centers for the anti-abortion movement. That is such a perfect way of framing it. I am now going to pass it over to Layla, who will get us started with Catherine. Thank you.
Okay, great. Our next panelist is Catherine Riley, who's a she, aya pronouns. Catherine is a queer, Mexican, Salvadorian American, born and raised in Texas. She has a BA in anthropology from the University of California, Santa Cruz, and a dual master's in social work and international development from the University of Denver. Catherine's lived experience with abortion and 10 years later, an empowering and supportive birth, have deepened her commitment to reproductive justice as the policy director at Color. Catherine is proud to have led in the passage of the Reproductive Health Equity Act, which protects our right to abortion and birth in Colorado, to have expanded prenatal and postpartum health coverage to immigrants regardless of citizenship, and to have prohibited deceptive practices from anti-abortion centers. She loves to travel and is a new mom to her 18-month-old Louisa. Thank you so much for joining us, Catherine.
Thank you so much for having me.
Okay, so just to get started, to talk a little bit more about your role at Color Latina, what movements is Color Latina engaged in and focused on in Colorado to counter the dangerous practices of anti-abortion crisis pregnancy centers?
Yeah, so just for folks who may not know, Color is a reproductive justice organization here in Colorado. It stands for the Colorado Organization for Latina Opportunity and Reproductive Rights. And last year, we passed a bill that did two things. The first thing that it did is that it prohibits deceptive advertising from CPCs. And the second was that it makes it unprofessional conduct through our medical licensing board to administer or prescribe abortion pill reversal or medication abortion reversal. everything that Jennifer said in her first, as the first panelist, is exactly the data and the information we use to get this bill passed, because we have the evidence and the data on our side. We know what these people are doing. And so we were super excited to be the first in the country to try to limit abortion pill reversal, and we followed in the footsteps of Connecticut, who was the first in the country to prohibit deceptive advertising. But our work, I'll say, did not start there. We started working in this space in 2018 when we worked on a Spanish billboard campaign. We had identified areas around the Denver metro area that had a high population of immigrants or Spanish speakers that also had one or more CPCs. And we posted billboards to let folks know that there was a fake clinic in their neighborhood and provided them with a website that they could go to for more information. Since then, and since the passage of our bill, we're continuing to educate and speak about CPCs to our Spanish-speaking community with social media videos, webinars, and tips on how to help folks ID CPCs. We've even had folks come up to us in one of our webinars and say, pull up the website and say, I just went here last week while I was having a miscarriage. Is this a CPC? And it was. And they just sent her home, and she was still bleeding a week later when she attended our webinar.
Wow.
Wow. I wanted to touch on something that you mentioned a little bit earlier. Could you speak a little bit about what abortion pill reversal is and why it's such a dangerous practice that crisis pregnancy centers are kind of advocating for?
Yeah, so abortion pill reversal, also known as APR or medication abortion reversal, is this idea that giving folks progesterone after they've taken the Miffy, which blocks progesterone, the mifepristone, excuse me, for folks who may not know, the first pill in the medication abortion regimen. CPCs believe that if you just OD people through an oral or injectable progesterone, that it will actually stop the reversal, and this is not the case. It's very dangerous. We had Dr. Mitch Cryanin, who is the only person who has ethically studied abortion pill reversal, testify on behalf of our bill. And I will say that obviously there are the physical dangers, which are frankly not even clear because the study that Mitch Cryanin did had to be halted because 3 of the 12 participants were hospitalized. And so moving forward, we can't even really ethically study this anymore because it's a danger to patients. In addition to the physical harms, I'll say that it also builds upon the existing mistrust that folks have in the healthcare system. A lot of people of color, queer folks, immigrants, non-English speakers have this mistrust in our system for very good reasons. And if they go to a place that claims to be administering a safe and proven treatment, and they later find out that this isn't true, there's even more reason to not trust doctors or providers in the future. And the last thing I'll say about APR is that it further stigmatizes abortion by implying that people regret this decision. We know, in fact, that 5 years after an abortion, more than 95% of people say it was the right decision for them. And so this idea that all these people are coming in and wanting to reverse their abortion after they take the first pill is just really harmful, dangerous, unethical. It's a lie.
Thank you so much for highlighting that, Catherine. Pivoting a little bit, how do you see the policy endeavors that CALOR is taking on expanding in order to ensure a more comprehensive access to abortion in Colorado for the Spanish-speaking community and for others? Just if you wanted to talk a little bit about that.
Yeah, so first I'll just say that while I am the policy director and I work in legislation, I don't believe that policy wins and legislative efforts are the answer to all of our problems. I think there's incredible work to be done in the organizing and grassroots campaign space. And even with policy initiatives and wins, there's a lot of this organizing and grassroots work that has to be done to just let people know that this is even a new law or, certain enforcement mechanisms that are now in place. So I just wanted to put that out there. There's so much work around CPCs to be done that's outside of policy. But that being said, we just passed this bill last year. Some of you might know that as soon as the bill was signed, just a month before our bill passed, we had to defeat one of those. So they're still coming for us, even in a state that is seemingly safe. So I would say stay the course. We have the science and the data on our side. They want to wear us down. They want to drop lawsuits and injunctions and all these things to get us to slow down. So just keep going at it. And it's also a really good opportunity that even though APR can still go on right now in Colorado, the message is out there, right? Like there's news reports, people are talking about it. We had the Colorado Medical, Nursing, and Pharmacy boards all were unable to say that abortion reversal was a generally accepted standard of care. So the word is out there. I feel like we are lifting the veil on this deceitful practice and to just keep going.
Thank you so much, Catherine. I already see lots of questions coming in for you, so we'll definitely hear from you later in the Q&A. Thank you so much.
Thank you.
Awesome. Thank you, Catherine, and thank you, Layla. Before I introduce Dr. Sarah Immerschein, want to make sure that, Sarah, you're able to speak now. I do believe you're on the line.
I'm on the line.
Oh, it's so
Can you
great
hear
to
me?
hear your voice. Yes, I can hear you. So,
It's been a long time.
It's been too long. Let me just indulge a brief introduction of you. A board-certified OBGYN, abortion provider, and past chair of the DC section of the American College of Obstetricians and Gynecologists. Dr. Sarah is a clinical professor at GWU School of Medicine, where she teaches the medical school curriculum on abortion, miscarriage management, and ectopic pregnancy. Dr. Sarah serves on the board of Americans United for the Separation of Church and State, as well as Reproductive Freedom for All, formerly known as NARAL. And she works as an abortion provider in Northern Virginia and is a founder of Grace Reproductive, a nonprofit clinic in Northern Virginia, which plans to open later in 2024. Congratulations, Dr. Sarah, and thank you so much for joining us today.
It's wonderful to be here, and I thank you, Erin. It's been a long time since I've seen you. Jennifer and Catherine, your contributions to, the knowledge and the factual information here about how common these clinics are is really important. So you want me to just talk about the clinical impact?
Yeah, I can ask you a question or two, and you can take it. So you come from a unique lens on our panel today. As an abortion provider, specifically, why do you see the tactics that anti-abortion crisis pregnancy centers use as dangerous?
Well, there are a couple of reasons. In medicine, we worry about the common and we worry about the dangerous. And in the diagnosis of early pregnancy, it's easy to miss an ectopic if you don't know what you're doing, which is a life-threatening complication, and it's easy to miss a miscarriage. But one of the biggest problems that we have seen in the abortion clinics is people coming in further along than they thought they were. These clinics often make up numbers. They tell patients, you're actually 6 weeks when they're really 9 weeks. So when they go to get a procedure, next thing you know, they've waited 3 weeks instead of being 9 weeks. They're now 12 weeks, and they're, further along, greater risks. Also, sometimes they'll say, oh, everything looks fine. It's actually an ectopic pregnancy because the person doing the actual sonogram isn't adequately trained. Now, I will tell you, in most of the clinics across the country, the sonograms are initially done by not licensed clinicians, but at every abortion clinic, a licensed clinician reviews that sonogram to make sure the report with it is accurate. So I don't think they're keeping those kinds of records. Patients come to see us saying, I went to this clinic and they told me I wasn't as far along as I was. It can go the other way. So they tell them they have lots of time to make a decision, which is dangerous. It also, for people who are ambivalent, and, we send people home all the time saying, if you're not sure, take a week and come back and see us if you want to go ahead with the abortion, and if not, here are some resources for prenatal care. And that's not so uncommon in clinics. And early prenatal care is so important for determining how far a pregnancy is along to make sure that later on, when it's less accurate for an overdue or premature pregnancy, and to also make sure that the pregnancy is appropriately growing in the uterus. So also starting vitamins and things like that, and other activities that should be modified for pregnancy. I also like to bring up, you talked about taking advantage of people of color. That's absolutely the case. And more importantly, just people who are poor. 40% of the babies who are delivered have their pregnancies paid for by Medicaid. Okay, about 75% of the patients seeking abortion care are poor or near poor, which means up to 200% of the poverty level, or about $29,000 income a year. 75%. So people who travel, people who end up in the wrong place because they took time off from work and they're already low income are going to be doubly penalized by delays in care and confusion and misinformation. So I think that's really important. Also, telling people about the reversal is absolutely, that study is well known in the abortion care community, that although it sounded good, give people progesterone and counter their progesterone blocker, in reality, people hemorrhage. And hemorrhage to the point of requiring hospitalization and transfusions. So you're right, we can't study it anymore. It's not ethical.
Thank you so much for that explanation, Dr. Sarah. I'm struck just listening to you, how at every turn it seems like, and forgive the football analogy, but I'm getting more into football with Taylor Swift and things that have been happening in that realm. But like, it really seems like run out the clock is a huge strategy of these CPCs. Like, I've seen it before in my clinic defense and clinic escorting, how the CPCs will actually put on vests of their own to make it look like they're the clinic escorts and offer people snacks, because that'll, in many cases, that means that their procedure needs to be delayed because you're supposed to do it on an empty stomach, or a number of providers want that. But also to hear you talk about, I actually hadn't heard that one before, about how they'll tell people that they're earlier along than they actually are. I mean, just the sheer fact that, and we know now with the abortion access crisis in this country that's been wrought by Dobbs, that timely access to care is harder than ever before because of the onslaught of patients coming in from places where they don't have. So I'm really struck by that and time and how to do that. One
in places like,
oh, go ahead.
I was just going to say, in places like Texas, which have a 6-week ban, they actually tell patients they're too far along and won't be able to access an abortion. That's one of the things I've also heard. And of course, for some of those patients who are very early, they could be ectopics because they have not been able to identify the pregnancy in the uterus.
Oh, well, it's just terrifying because, also hearing you talk about the reversal, it's like somebody's going to get really hurt at some point from what's happening under this medical malpractice. And I want to thank Shireen, our EVP and Chief of Staff, who just put in some information about all the work that we've done on anti-abortion paid clinics and abortion pill reversal. I'm seeing a number of questions starting to come in. So you know what I'm going to do? I'm actually going to keep us moving unless there's something you'd like to say briefly, Dr. Sarah. And then
the only other thing I want to mention is that I think most of us are trying to avoid calling these storefront places CPCs or crisis pregnancy centers. It feeds into their language, and we're calling them fake clinics, because the real crisis is in the people who will go to them and they don't provide prenatal care or any early pregnancy. So I think many of us are moving away from the language of CPC and just calling them what they are, fake clinics, especially when we're lobbying and advocating for more information. Be honest.
This is Catherine, and I'll just jump in to say that when we passed the bill, we were very intentional to call them AACs, or anti-abortion centers, and we had fake clinics, one of our documents, and that got them so rattled the other side. They wanted us to take out fake clinic, and it made us keep it in even more because we liked that they were upset about that. So yes, I agree with that.
Mm-hmm.
Thank you for that. And I'd also like to open that up to Jennifer briefly on what you like to call them through your work, if you have anything else you'd like to add on that front. And unfortunately, for some reason, my computer is freezing on the typing front, so I'm unable to unmute Jennifer, but Layla or Serena, if you could help me with that, I'd appreciate it.
Okay, so I'm unmuted, but can you type the question?
Yes, I'm struggling to type right now. Unfortunately, if Shireen or Layla, you could do that, but just type out the question. Jennifer's preferred term for whether she likes to call them crisis pregnancy centers, anti-abortion centers, anti-abortion state clinics.
Okay, you want me to weigh in on that question?
Yes, please.
What to call them? Okay. Yeah, it's a mixed landscape. I mean, I see the upside of calling them anti-abortion centers, anti-abortion pregnancy centers, and the crisis pregnancy crisis pregnancy center moniker, is their own language from over many years, and it's still used in in policy spaces. So the accountability measures that are coming up on the local and state and federal level, are identifying them as limited service pregnancy centers and or crisis pregnancy centers. And so it's difficult to make the shift entirely. And I also think that they're more than anti-abortion centers. They're proselytizing, they're promoting, evangelical, traditional, family structures, and they're anti-contraception. They're blocking access to all reproductive health care. So I think that, the downside of calling them anti-abortion centers is it doesn't capture the range, neither does crisis pregnancy center, of course, but it doesn't capture the range of threat. So at this point, I'm toggling, sort of in talking about them and writing about them between, anti-abortion crisis pregnancy center, anti-abortion pregnancy center, crisis pregnancy center. And it's imperfect, but I think that's where we are.
Thank you so much for weighing in. And that's actually what just happened is a perfect example of why we host these Act and Learn webinars every month, because we know that that our extremely engaged activists and leaders, including at the grassroots level around the country, are often on the line, and I see lots of spirited questions and comments coming in. And this is a place where we're also, our Act and Learn webinars are a space to kind of talk about strategy and things of that nature. So it's clear there's still a number of different approaches that are being used, and it's really helpful to hear where people are coming from and what's been successful for them. I am going to steer us now to Layla to give a brief plug for our campaigns, and then I'll talk about next month's topic, and then we'll open it to the Q&A. So anyone who has questions, feel free to put them in the questions tab now. I already see several have rolled in.
Great, thank you, Erin. So just really quickly, wanted to let everyone know that they can sign up for our alerts and emails at reproaction.org. If anyone is interested in hosting a self-managed abortion information session, you can scan this QR code to sign up, where we kind of take people through the different protocol for self-managed abortion. And also make sure to follow us on our social media. We're Reproaction everywhere: Facebook, Twitter, now X, and Instagram.
You'll want to sign up on, if you're not already receiving our email alerts, you can sign up at reproaction.org, and I promise you'll get the invitation. But in the meantime, we're going to talk about abortion on the ballot on Monday, February 12th at noon Eastern. I mean, it's just an exciting time that abortion has won every single time it's gone on the ballot, no matter what political climate it has gone on the ballot in, no matter what really bad faith, inaccurate and hostile language the anti-abortion movement has used, or barriers that they've tried to put in place to people voting. They're now admitting out loud that they don't want people to vote, which is always part of the end game. And upcoming ballot initiatives, what you can do, and we'll also, seek to complicate the discussion a little bit too. I mean, there's some legitimate debates to be had about what exactly goes on the ballot. So you won't want to miss that one. Please plan to join us. And now I will move it to Q&A. So the first question is an easy one with regards to Jennifer's report. We were asked if there was a place where people can see your report. Jennifer, is that a link that you can share back with us, and we can put it in the recap email that goes out to everyone? And we'll also, seek to complicate the discussion a little bit too. I mean, there's some legitimate debates to be had about what exactly goes on the ballot. So you won't want to miss that one. Please plan to join us. And now I will move it to Q&A. So the first question is an easy one with regards to Jennifer's report. We were asked if there was a place where people can see your report. Jennifer, is that a link that you can share back with us, and we can put it in the recap email that goes out to everyone?
Sure, I'll be happy to do that.
Oh,
yeah,
fantastic.
The report is online. So you can even Google Design to Deceive or Alliance State Advocates and find your way to it there. All of the sections of the report as a whole, each section of the report separately, and there are also some companion documents, including one on the global, national, and local anti-abortion groups that are supporting the crisis pregnancy center industry.
Thank you, and I see Layla also dropped that link into the chat. Thank you so much. So the next question that I want to share is very similar. This one's to Catherine. Is there a place where folks can see the anti-crisis pregnancy center billboard campaign that Kalor did that Catherine mentioned? We'd love to be able to do the same thing for our neighbors here in Wichita at Trust Women. I'm pumping my fist for that. Catherine, is there a way that you can share with us? And it doesn't have to be here on this call, but if there's any links online or pictures of them or something that we're able to share back in our email that goes out to everyone, we'd love to share that.
Absolutely. I'll share some stuff with Layla. We have photos of the billboards as well as a few news articles.
That is awesome. Okay. The next one I'm going to put to Dr. Sarah. Can you expand about the dangers of progesterone in the abortion pill reversal protocol? And I just want to also kind of do a little air quotes around protocol on this as well, just because, again, this has not been subjected to peer-reviewed studies. This is literally anti-abortion actors with lab coats that they bought at the costume shop making crap up. So just want to cast that shade as well. But Dr. Sarah, can you talk more about, the concerns about that?
So there are a couple of things. First, there are some dangerous anti-abortion OBGYNs. Giving this information is a reason to be reported to the board, but people can still have their medical licenses. And they came up with these protocols to try to reverse abortion, medication abortion. Medication abortion, as most of you know, are two medications taken 6 to 48 hours apart. The first medicine is an anti-progesterone. The hormone progesterone is made by all females who are cycling in the latter half of their menstrual cycle, right before your period, for about 2 weeks, and that maintains sort of a pregnancy if one lands in the uterus until the pregnancy can sort of take over, making the progesterone itself. And progesterone prevents the body from rejecting the pregnancy, and it keeps the pregnancy going. Until about 12, 14 weeks, the body makes progesterone. So by taking the mifepristone, you block up all that progesterone that is normally made, and the pregnancy really can't take hold. And the second medication basically causes the body to expel it. If you took the first one alone, it'd be a long time till your body woke up to expel it. So what they are doing is trying to get to people within this, 6 to 48 hour period before they take the second medicine and say, okay, if we blocked up all the progesterone in your body, we'll just give you more progesterone. But if the medication is something that like is a key that doesn't fit, and it gets into the progesterone receptor, and you can't get the key out, it's stuck, it will block progesterone, whether you take it by mouth, whether you take it by a cream, whether you take it by an injection, which you can put progesterone in your vagina, all those ways, it's very well absorbed, but it's not necessarily going to overcome the blockage that the mifepristone has caused. So what happens with all that progesterone? You get a whole bunch of progesterone, your body's already making progesterone that's not reacting to. And what happens when your body stops making progesterone? You get your period. That's what happens normally if you're not pregnant. 2 weeks after you ovulate, you stop making progesterone, and that's why we call it withdrawal bleeding. So these patients are bleeding very, very heavily. And as was mentioned before, the study that looked at this in a scientific way was stopped by the reviewers, by the ethical guidelines, because, as mentioned, 3 people ended up hospitalized for hemorrhage. So just because you think, oh, we're blocking progesterone, we'll just give her progesterone, doesn't mean giving progesterone will undo that blockage.
Very worrisome, and it honestly, it just makes me angry as well for all of the ridiculous concern trolling that the anti-abortion leaders have taken on about their supposed concern for women's health and safety. Is just such crap when they're like exposing people to this. This is a really interesting question that to use as a springboard, and let's start with Catherine on this one. So the question is, have there been any efforts to work with crisis pregnancy centers so that they support abortion? I think that seems extremely unlikely. Or is the goal to shut them down completely? I'd actually just suggest expanding the question, because I mean, the reality is that there are needs that exist for people to have greater support during prenatal care, people who are continuing pregnancies, and people who have low income and need support who want to have children. So like, I'd just love to hear you talk some more about like, what's the end game here?
Yeah, that's a really good question, honestly, and it's something that we wrestled with a lot when we were passing this bill, because what they offer as far as like diapers and, some baby clothes and things like that really is because our healthcare system is failing people throughout the perinatal period. So prenatal, postpartum, all of that. So there is a need for all of these services for folks to get them somewhere else. So when we were passing the bill, we were considering, do we add money to a bill that had passed the year before that upped funds for diaper banks in Colorado? Like, what else can we do? In the end, we opted not to do that because it would have had a cost to the bill, and we didn't want that. It's harder to pass that way. But we know that our people still need some of these services. So for us, when we were passing the bill, we were very clear that no, we're not trying to shut these folks down, at least, not yet, and not in this way. What we were really asking them to do was to be honest. And if you go to their website and it says, come talk about all your options, or people are wearing lab coats, or they have a mobile van clinic that seems to be licensed and run by licensed providers, that's deceitful, that's manipulative, that's a lie. So we were saying, it's cool if somebody comes into your CPC or your fake clinic knowing that they're getting biased, one-sided advice, and that's what they're looking for, that's fine. But if you're luring people in by saying, hey, we're going to give you all your options, all your information, and all of these other things, playing upon shame and stigma, that's not okay. And that's what we were trying to stop with this bill. As far as working with CPCs in Colorado, I can tell you they do not want to work with us. They were showing up in full force at the Capitol to oppose this bill. So no, I wouldn't say that that's the next path, but I think there is something to be said about maybe our side starting to have some kind of pregnancy resource center, or being able to add all of these other services to abortion providing sites. I don't know what that looks like. It's out of my realm, but yeah, I think there's a gap in our system and we need to fix that.
Co-sign, and Jennifer is going to weigh in as well. Oh, looks like we're having audio difficulties. I'm unable to.
Okay, I just was able to unmute myself there, so I'm here. So thanks for this question, and thanks, Catherine, for your thoughts on this, and Sarah for your thoughts on the sort of from the clinical perspective, sort of what some of the dangers are here. I have two responses to that question. One is we as a country, obviously, the national and particularly at the state and local level. Catherine, for your thoughts on this, and Sarah for your thoughts on the sort of from the clinical perspective, sort of what some of the dangers are here. I have two responses to that question. One is we as a country, obviously, the national and particularly at the state and local level, need to be meeting the actual needs that healthcare needs and material support needs of pregnant people and families. We're abysmal in doing that in this country, which is a reality that the CPC industry exploits. So, local efforts and state efforts actually invest in, making material, providing material supports that are not conditioned on, a particular provider's ideology is critical. And capacity building for reproductive health care. We're abysmally behind on that in this country and disabled, and because reproductive health care has been so politicized. And I'm encouraged there are efforts to do that, sort of emerging that are new, to really build the capacity of, sort of full spectrum reproductive health care providers, both in abortion, destination states, and in abortion banning states. I mean, my program is actually investing in helping to transition former abortion clinics into full spectrum reproductive health care providers that also refer for abortion and sort of function as abortion funds as well, and do the diaper part, and do the mobilizing volunteers part. And then there are also policy efforts to, sort of to address the lack of reproductive health care policy supports in this country. But I think the ultimate goal, in a way, with the CPC industry is to neutralize them. And one way to do that is to disrupt, in a critical way, disrupt their ability to claim to be medical. So they're not medical. So if they want to say, well, we're little church-based groups that, provide diapers, and, a handhold to pregnant people who are looking for diapers and a handhold from a religious group, fine, do that. But they can't operate in a regulatory gray zone. They can't claim to be medical when they're not. They're not going to want to do that. But I think that's our sort of, I think that's one of the end games, is to really expose them for what they are, make it toxic to participate, in supporting them, and disrupt their ability to claim they're medical.
Thank you for that. And that's the perfect note to end on. I want to thank all of our panelists, Jennifer, Catherine, and Dr. Sarah, and especially thank Layla Salam for pulling together this webinar. We can't wait to see you next month. We will be sending out the recording. Have a wonderful rest of your day. Bye.